This is an example of a metastasis-bearing rotor node. Here's the pectoralis minor muscle behind the lesion, pectoralis muscle major in front of it, and this is a metastasis-bearing rotor lymph node. There is a large vessel that runs between the pectoralis muscles, and this is a normal vessel. Now, the first case I showed you had level 1, level 2, and level 3 nodes. So in that case, we want to go at least one level higher. So we did. These are supraclavicular lymph nodes. They're morphologically abnormal. These are jugular lymph nodes. They're morphologically abnormal all the way up to level 3 in the neck. There are levels of cervical lymph nodes as well. And these are posterior cervical lymph nodes. These are the farthest from the axilla abnormal lymph nodes we saw. So in this particular case, we did a core biopsy on level 1 nodes in the axilla, and I did an FNA on the highest jugular lymph node to prove that these were all metastatic breast cancer. We can see normal internal mammary lymph nodes. Some of the literature has suggested that that is not the case, that we cannot see them. Normally they're 5 to 7 millimeters in long axis. We usually see them in the second and third interspaces, and they're most commonly seen just above the costal cartilage, which lies right here. But they can be seen anywhere along the intercostal space. Spatial compounding can help because it brings out the capsule of the lymph node. Notice that we tend not to see the hyperechoic or echogenic hilum that we see in axillary lymph nodes. This is because that's often the case in smaller lymph nodes, and I think because the resolution that we scan with is reduced because of reflection and refraction of the beam by the intercostal tendons. In older women who have congestive failure and increased right atrial end diastolic pressure, the internal mammary veins can become very dilated and tortuous, and it can be difficult to sort out what might be just a tortuous internal mammary vein from lymph nodes. So color or power Doppler can be very helpful in that respect. This, by the way, is simply a reflection artifact off the interface of the lung. That's not real. It's a reflection of this internal mammary vein lying anteriorly. Sometimes you can use fremitus to help you find internal mammary lymph nodes because they vibrate differently from the intercostal tendons. Notice how the artifact is transmitted beautifully through the intercostal tendons and muscles because they're oriented in a plane that's perpendicular to the lung, and they allow the vibrations to climb out of the lung really well. But the lymph node doesn't transmit the fremitus well, so you can outline the internal mammary nodes by using fremitus in some cases. Some of the literature talks about a 10 or 15% risk of internal mammary metastases. We find it to be less than that. We find the cases where it's most likely to occur to be large, deep medial lesions, because the deep medial part of the breast may preferentially drain to the internal mammary lymph nodes. But most medial lesions drain to the periareolar sapes plexus and then to the axilla. So when we most often see abnormal internal mammary lymph nodes is when there's so-called tumor damming in the axillary lymph nodes. This is a fairly large 2.5 centimeter high-grade invasive ductal cancer. There's gross metastatic disease within the axilla, lots of completely replaced nodes. These nodes are so replaced that the lymphatic channels draining to them are obstructed, so the patient has developed collateral pathways that drain through the internal mammary nodes, and that's when we find gross internal mammary lymphadenopathy. Now, we have tended not to perform FNA on these internal mammary lymph nodes to confirm that they are positive, but it is certainly possible to do this. One thing to keep in mind is that many so-called recurrent carcinomas within the chest wall post-mastectomy arise from unrecognized lymph node metastases. And I think if we do a better job of recognizing these prospectively, we can either help direct the surgeon to remove these or direct booster doses of radiation to attack these. But here's a chest wall recurrence. that really probably came from an internal mammary lymph node. And here are chest wall recurrences that I'm sure arose from broader lymph nodes. Here's the pectoralis major muscle, here's the pectoralis minor muscle, and this so-called chest wall recurrence is in fact metastatic disease in broader lymph nodes. Here's another case of a very severe chest wall recurrence. This is the sternum. This lesion is arising just lateral to the sternum, right where the internal mammary lymph nodes lie, and it's grown forward, and it's actually covering the anterior aspect of the sternum. So in summary, we always evaluate the axillary lymph nodes in patients that have suspicious or malignant breast nodules in whom we are going to perform an ultrasound-guided biopsy of some sort. If we find an abnormal lymph node, we biopsy it. But remember, a positive staging ultrasound is always more valuable than a negative. We can't see microscopic disease, we can only see gross disease. A grossly abnormal ultrasound leads to biopsy of lymph nodes and confirmation of metastatic disease. A positive ultrasound and a positive biopsy can obviate a sentinel node procedure, and that's our goal here, is to let the surgeon go straight to full axillary dissection and not have to perform the sentinel node procedure. It cannot obviate the axillary dissection. The patient is still going to need an axillary dissection in those cases. But remember that a negative staging ultrasound or a negative biopsy of an abnormal appearing reactive lymph node hasn't really accomplished much. The patient will have to have a sentinel node procedure if that is what the surgeon was originally planning, and it will just represent an extra procedure. The last thing I want to show you is possible future development. I'm not actually doing this, but this is being done at Thomas Jefferson University by Dr. Goldberg and others. And it's a lymphatic ultrasound contrast agent that can be directly injected into the subcutaneous fat. As of yet, this is being done in animals, rabbits and pigs, but not in humans. But you can inject directly into the subcutaneous fat. The hyperechoic contrast ascends the lymphatic vessels, fills the cortex of the lymph node, making it hyperechoic. It's been shown to correlate well with radionuclide methylene blue dye injections. And it happens in a matter of seconds to minutes. Here we can see a pig lymph node filling from the inside out over a matter of about 40 seconds. Here the cortex is completely filled with contrast. Now notice that this is filling in the opposite direction that I told you lymph flow occurs in humans, and that's because this is in a pig, not a human. Humans would indeed fill from the subcapsular sinusoids inward. But the important thing is that where there is metastatic disease, the contrast doesn't enter. The lymphatic channels of the lymphatic sinusoids are blocked. So this is a lymph node almost completely replaced with metastatic disease. There's only a small area of cortex that's still normal. That is the area that fills with contrast. This is all area filled with metastasis. Now the contrast isn't particularly helpful in this case because this is so obviously abnormal. We'd easily be able to detect this with ultrasound without contrast and easily guide our needle to the correct part of the lymph node. But that is not the case in this particular situation. Here most of the lymph node is normal. There's only a small metastasis bearing area of the lymph node, but we can pick that area out because of the lack of contrast enhancement. This might be a morphologically normal lymph node on grayscale ultrasound alone. So not only would the ultrasound contrast agent help us determine that this is an abnormal lymph node likely to contain metastasis, but it will precisely guide our needle to the correct part of the lymph node to document that it is positive. So thank you for listening. I think it's important when we evaluate breast lesions that we try to help the surgeon and the patient as much as possible by at least doing some preliminary staging. I will not say that ultrasound is better than MR for staging, but I do think ultrasound is better than MR for evaluating lymph nodes And I think we should be aggressive in mapping out the extent of disease in cases where it helps. I don't think we should be too aggressive about biopsying lymph nodes that might be reactive because we just perform an extra procedure and don't accomplish anything. I think it's important that we go through the rigorous exercise of trying to determine whether metastasis or a benign reactive lymph node is the more likely etiology for the abnormal morphology before we commit ourselves to core biopsying or performing FNA on that lymph node. Thank you.